We are starting a very interesting panel here. Welcome all of you. I'm going to introduce myself first. I'm Dr. Lawrence Cohn. Of all the people here, I'm probably what's known as a blue-collar cardiac surgeon. I do cardiac surgery, but I also have a couple of other jobs with partners. One is I'm the physician director of medical device technology for the entire system. And at one time, I was the chair of the physicians organization at the Brigham and Women's Hospital, which, by the way, is 2 miles due west of where you are sitting right now. We are having a very interesting panel on accountable care organizations today. And our question for this very distinguished panel to completely solve for us today, without a doubt, will accountable care organizations produce accountable patients? And if so, how? I just want to take 1 minute. I know all of you experts in the audience know what an accountable care organization is, but they haven't actually been put into effect yet. It's part of the big new care plan that's been devised in Washington. And it's going to be a payment and delivery reform model that seeks to tie provider reimbursement to quality metrics and reduction in total costs and the care of an assigned population of patients. Thus, it's a coordinated healthcare provider will be central to this process. And it's supposedly going to be better coordination of care for patients. It's going to be incentives for providers to work together. So there won't be separate fee for each visit to the internist, to the cardiac surgeon. It'll all be one wonderfully cooperative, harmonious package. And the question we have before us today, since the patient is at the center of this, they have to be part of the team. And this is going to be a very interesting kind of pragmatic problem to work out, because if the patient doesn't cooperate, if we can't get them to play on our team, we all have a bit of a problem. Now, we have a very, very distinguished panel here today. To my immediate left is Dr. Timothy Ferris, who is the medical director of the MGH Physicians Organization, senior scientist, partners MGH Institute for Health Policy, but more importantly, he's a primary care physician, and he practices and takes care of these kinds of people that will be part of the ACOs. To his left is Jonathan Gruber, who is a professor of economics at a local college, I think it is, Massachusetts Institute of Technology. It's across the street. It's a local sort of a place, good place, really good place. And finally, on the far left, Dana Safran, who is the senior vice president of Blue Cross and Blue Shield of Massachusetts, who is very, very interested in the quality of healthcare, which she's done all of her professional life. So what we have here, we have the provider, Dr. Ferris. We have the payor, Dr. Safran. And then, of course, we have the economist, who's the expert on all matters related to healthcare, economics, and policy. Do I get that right? Okay. I'm now going to introduce each one of them, who are going to introduce their background, their thoughts about this important problem. And the first will be the healthcare provider, Dr. Ferris.
Would you like me to go to the podium?
Yeah, as you wish. At least for this part.
And for the moment, I should go into the whole
Just give your whole thing. Give your slide.
Okay. All right. Well, so in the interest of being a little bit provocative,
Good.
I have 3 answers to the question of whether or not ACOs will engage patients, and each one will be subsequently more nuanced. But the first answer, in order to be provocative, is my short answer, and my short answer is no. My short answer is that patients will need a separate set of incentives to truly get engaged as a member of the care team. Now, having said that, the next answer is a little more nuanced. And the longer answer is, if it goes well, then there's a chance that patients will be engaged in this process. And I'm going to ask for my slide and use my slide as the heuristic here. So this is a very busy slide, but I want to spend just a couple minutes going through the organization of the slide and not spend time on the details. Because this is, to the group of people that I work with, how you succeed as an ACO. These are the specific tactics that one must use to succeed as an ACO. And what I want to do is look within these tactics and find which one of these tactics actually will help engage patients in the process of care. And there are some tactics in here that will engage the process of care. So if we're going to succeed as an ACO, we're going to have to improve access to care, things like patient portals, extended hours, same-day visits, virtual visits. That's a form of engagement. That's something that providers can offer to patients that provides a bit of engagement. That's under the access to care section. Under the design of care, you'll see a square there called required patient decision aids. So if we required patient decision aids prior to our going in and doing surgery, that's a degree of patient engagement that I think is important and necessary in the process. You'll also see a high-risk care management. That's the hot spotting thing. I think Atul Gawande is here somewhere. And you know, in the engaging high-risk patients, there's all kinds of things like telemonitoring. That's a form of engaging patients if you can get them in that, the high-risk patients engaged in that. And then there's incentive programs for doctors, and I'm not going to go through this list. This list isn't, I'm not wedded to this list. It's not the answer. It's one list of answers that a group of people who got together who are going to try to do this are going to use as a guide to succeed in this. So there is some patient engagement in this, but this is mostly the work of the people who are getting this incentive under the ACO model. And so my third answer is, you said, you may have noticed in my second answer I said, if it goes well. So why might it not go well? And when I think back to the 1990s, when I was practicing as an internist in a health center in Chelsea, there were, and I lived under the capitation, there were several aspects to the what was then, in many ways similar, I would argue, to what is being proposed. Some pernicious aspects. And those pernicious aspects ended up becoming quite profound. There are two studies that I like to cite with respect to this. One is, what % of Americans who were in managed care or not in managed care thought that managed care was hurting them personally? And it turned out that there was a 50-50 shot between those who believed it was hurting them and those who didn't, based on whether or not they were actually in managed care. So the answer was, Americans believed managed care was hurting them personally in their care, even if they weren't in a managed care plan. They didn't actually know the difference, but they believed that managed care was hurting them. Why did they believe that? I think they believed that because their doctors were very unhappy, because their doctors were in managed care plans, independent of whether or not that patient was. And I believe, actually, I like to cite this, but it was Dana Safran who first introduced me to the idea that one of the best predictors of a happy patient is a happy doctor. So what might go wrong here? What might go wrong is if expectations for patients and doctors aren't real clear going into this, that this may start off looking pretty good, but it could run into some trouble down the road if people start to believe that they're not all on one team, that their doctors are getting incentives to stint on their care, and that sets up a negative, self-reinforcing dynamic between doctors and patients. That will undermine the prospects for an ACO in engaging patients in the process. Thank you.
Okay, Dr. Safran.
Good morning. So I would say, in answer to the question of whether an ACO will produce accountable patients, I will give a very strong yes to that. And in fact, will say that we already see that happening through the model that Blue Cross Blue Shield of Massachusetts, where I work, has introduced into the market. So I want to give you a few points about why I think that's the case. And I'll say that, what Blue Cross has introduced, oh, it's not on the screen yet, that's good, is a model that fundamentally changes the way that we pay for care, is in many ways quite different from the problems of the 1990s that Dr. Ferris points to, but has in common with that introducing the idea of accountability for the full continuum of care. Now, there's far too many people in this room to do something that I did in a meeting last week that was enormously helpful, but I went around and asked each person with one word to say, what do they think is the biggest problem with the healthcare system today? And if I had to summarize what I heard back, it was fragmentation, it was chaos, it was the lack of anyone talking to anyone else, and the patient and the family and the role of holding all the pieces and having to carry those pieces. And fundamentally, that is the problem that the ACO looks to solve. And I think that if we can, and I believe that we can, have clinicians and healthcare organizations behaving differently because the incentives are different, that patients will very quickly come to understand that this is finally a model that's trying to give them the answer to what has been their biggest problem with the healthcare system for their whole lives, and that is fragmentation. And so one of the other things that I think is important to think about as we ask ourselves this question about whether ACOs will produce accountable patients, that brings up, of course, the issue of adherence, right? Or some people call it compliance. But the question of when the patient walks out of whatever clinical encounter that they've had, whatever hospital stay they've had, will they do what they've been asked or told that they need to do to take care of themselves? That's the question we're talking about. Will the patients be accountable, or will it just be the system that's accountable for outcomes and for the spending and utilization that happens down the line, but you have these patients that are walking out and really not helping? Well, to really think about that question, I'd like you to consider that there are only about 4 things that are potential barriers to patients leaving a clinical encounter, leaving a hospital stay, and not following through on what they've been asked or told to do. There are cognitive barriers. Did the patient understand what they were asked to do? Either for cognitive processing reasons or for language reasons they may or may not have. There can be motivational barriers. The patient just wasn't convinced that it's the right thing to do. There can be practical barriers, day-to-day things in their lives that get in the way of their being able to manage themselves and their diet and their lifestyle and their medicines in the way that they've been asked or told to do. And there can be financial barriers. So there are 4 types of barriers that get in the way to patient adherence. And in my view, an ACO model, or what we've done with the alternative quality contract, by asking healthcare organizations to take accountability for that full continuum of care, to have very strong incentives on quality measures at the same time that they take responsibility for the total cost of care. So that balance that we didn't have in the 1990s, that yes, you have to be very conscientious about the way dollars are spent, but at the same time, you have to ensure that the quality that you're getting from however you're spending or not spending dollars is high, and that patient outcomes are favorable. So we didn't have those counterbalances, that backstop against stinting on care in the 1990s that we have now, and that's a key difference. But these organizations now have a very, very strong set of reasons to address those first 3 barriers that I talked about. to make sure that patients understand what they're being asked to do, to explore with patients the motivational barriers and the practical barriers. What actually does it look like out in your life? How hard will it be for you to do these things? Rather than, writing a prescription or making a recommendation about lifestyle and just hoping that when the patient walks out the door that will all work out. There's a very different level of engagement with that whole set of issues that we already see happening, having introduced a model that creates this accountability for total spending and for quality and outcomes. The fourth piece, the fourth barrier, financial barriers, that's in large part, that's a health plan's job, right? That's the health plan's job to structure things in a way that there aren't financial reasons that patients walk out the door and don't do what they've been asked to do clinically, to make sure that benefits cover the things that are very important for quality and for outcomes for patients. So I think that I'm extremely optimistic, and already I, in fact, see in our network evidence that accountable care organizations are, in fact, engaging patients in a very new way, asking them questions that patients really experience as patient-centered care, sometimes for the first time in their lives, that enable them when they leave the practice to go and carry forward the things that they've been asked to do, to understand them, be motivated to do them, and overcome the practical barriers. It's our job to make sure that there aren't financial barriers there. So let me leave it there.
Dr. Gruber?
So I guess I'm supposed to come up and say maybe. We've got a no and a yes. I guess I'm leaning a bit more towards no than yes. And I guess where I come down on that is that ultimately I'm focusing on the issue of cost control. And ultimately, if accountable care organizations are going to control costs, it's going to ultimately mean patients get less intensive treatment than they do today. And we hope that they get less intensive treatment in a way which does not harm their health. We think there's a lot of wasted care out there, and we think by ending that fragmentation, we can coordinate care and end that wasted care. But along the way, patients are going to get less than they get today. And the question is, will patients be willing to do that? Or will we return to the 1990s? We could come back to the 1990s. That was the relevant experience. Remember, we've only had one 2-year period in the history of our country since World War II where healthcare costs have grown as slow or slower than inflation, and that was in the mid-1990s when managed care took off. It did at least temporarily control healthcare costs, but what happened, there was a patient backlash against managed care. And why was there a patient backlash against managed care? Because patients were not seeing the benefits that managed care were bringing. What benefits is managed care bringing? Higher paychecks. That ultimately, I think it's not a coincidence, although I can't prove it, that was also the only period of time since 1973 that we've had a large increase in real wages in our country, was because we got the cost of healthcare under control so employers could pay more to their employees. But that link was too indirect for patients to see. They didn't see, gee, this extra hassle I'm going through, having to wait a bit longer, getting things pre-approved, that's making me richer. They didn't see that link, so they revolted. They made that move with Jack Nicholson. Everybody got upset, complained about it, and managed care wilted away in effectiveness. Now, Dana's hope is that managed care 2.0, which is what accountable care organizations are, will be better than that. There'll be rewards for quality. We'll put incentives to try to deal with this. I guess I'm less sanguine. I think we're going to run into the same problems unless we put the financial pain on the consumer of not having accountable care. And so ultimately, I think if we're going to control healthcare costs, accountable care organizations are really just one leg of the ultimate three-legged stool we need. One leg is reforming provider payments, which is what accountable care organizations do effectively. The second leg is improving consumer accountability. And the third leg is objective comparative effectiveness research, which both consumers and providers can point to when they say, look, you're not getting this care and here's why. I think accountable care organizations by themselves will not do the trick. They will not make accountable patients. But I think as part of that larger system, they will. And I think, I'm hoping we head that way. I think the Affordable Care Act starts us down that path. In terms of consumer accountability, it starts us down that path by imposing what we call the Cadillac tax, which is to try to end the expensive and inefficient subsidy to employer-provided health insurance that causes people to use excessive medical care. In terms of provider fragmentation, it sets up incentives and pilots for the kind of accountable care organizations that have been so wonderfully piloted by Dana and the folks at Blue Cross with their alternative quality contract. And in terms of comparative effectiveness, it sets aside $1 billion for research into comparative effectiveness that can ultimately form the basis for providing an objective source that both providers and patients can point to when we say, no, you shouldn't get that back surgery or that other type of treatment. But we're a long way away from that. All of those are very modest steps in that direction. And I think it's important to recognize that we need to move forward strongly along all three dimensions before we can really create the kind of accountable patients and the kind of overall accountability of the system that will control healthcare costs.
Well, thank you, folks. Now you've heard the provider, the payer, and now the expert. So I'm sure you all come to the right conclusion on this. I'm going to take the privilege of the moderator, ask a couple of questions and see how you all want to take care of this. Now, I do heart surgery in my spare time, and this recovery of some of these patients is a little complex. But what are we going to do in these kind of situations where if I say after an aortic valve replacement, I don't drink any liquor for a couple of weeks and don't indulge in a lot of hot dogs and salty foods and take your diuretics just because you have a normal load of extra fluid on board, and you'll recover quite nicely. So a patient goes home and he starts, oh, I'm so happy to be, I survived, I'm alive, and he starts drinking a bottle of wine every night and he doesn't take his diuretics, and 2 weeks later he's back in the hospital, readmitted with heart failure that he or she herself brought on them under the accountable care thing. Now, I'm told that in the future there may be these global payments, and that if you're going to be readmitted for something within a 30-day period, the hospital and the doctors ain't going to be paid. Would you like to comment on that, Dr. Safran? How does that fit into this kind of situation, even though, as you say, we've instructed him, we've had visiting nurses, but he's not accountable?
Sure. It's a good illustration for us to grapple with. And what I'd say that we already see changing in a very important way under the AQC model, where there isn't as close a link as you say. That is to say, if that patient gets readmitted, the hospital actually does still get paid for that readmission. However, that readmission, which is expensive, counts toward the overall budget that the organization as a whole has to take care of its whole population. So organizations that have come into the AQC, and the first cohort came in 2009, and so is now nearing the end of the third year of their experience, are behaving in a very different way. We have, I've had hospital quality directors say to me that for the first time ever that their institution actually is making concerted efforts to be sure that things like lab results that hadn't been completed at the time that a patient was discharged get into the hands of the physician who's taking up care on the ambulatory side, because now it matters to them what happens after the patient leaves. And they'll say, look, I'm the quality director for this hospital and I'm embarrassed to admit it, but the truth of the matter is that under the traditional fee-for-service model of payment, that as soon as that patient is off our watch, it doesn't matter. So 40% of the time when labs didn't get resulted before the patient left, that information never left our building. These institutions are now working very hard to follow up on patients like this. A patient like that would never be out of a hospital for 2 weeks without very careful oversight. We have practices that are doing home visits, literally doing home visits for patients who they feel are the most vulnerable to readmission, and certainly a patient like the one you described who has congestive heart failure and perhaps a history of alcohol abuse would be on that list of patients at high risk for readmission, and they're managing those patients in a very different way. So I would say there's better odds than not that a patient like that under this model would not have been readmitted, and at the very least would have a much lower risk of readmission because the kind of care that's going to continue when they're in between settings, when they're out of the hospital but not yet back in the doctor's office.
Dr. Ferris, any comments on a patient like that?
No, I think isn't it a sort of classic story of how much is enough? Because on the one hand, and I know I shouldn't be on the one hand because that's what the economist is supposed to do, but on the one hand, that will everything that Dana describes in terms of reduction of the fragmentation will be part of a payment system that aligns the providers around the interstices between the silos of care that we've set up over the last several decades, and that will be a benefit. The question is, will it be enough from the perspective of the patient to bring the patient into the care team? There will always be patients for whom it's not enough, and just acknowledging that up front is important. And then the question will be, how bad are the penalties that are imposed for failures? And that's a matter, to me, not a difference in kind, but a difference in degree. If we do this carefully, I think we can thread the needle on that. But there's a lot of room to do this injudiciously in terms of the incentives. And that's, so I'm not, I'd say vigilance is in order.
Dr. Gruber.
Yeah, I think this raises a very important point in general, which is the tendency in this kind of debate to let the perfect be the enemy of the good, which is, I think Dane is absolutely right, that the incentives put in place in the AQC will work in the right direction. I also think that they won't get all the way, and I think that you need patient incentives as well. The patient needs to bear the consequences, because they can't, when they leave the house, the patient can still drink the bottle of wine. The patient needs to face the consequences. But I think we have to remember that even if we get part of the way, that's still a lot. There's a huge amount of waste and excess spending in the system, and I think there's a tendency to say we didn't solve it, so it didn't work. And I think, even the title of this session, will they produce accountable patients? It's not, accountability of patients is not a 1-0 thing. It's moving towards accountable patients. And I think Dane has described a great platform for moving us towards it. I'm arguing we need more, but I think we shouldn't say that just because we haven't gotten all the way there, we failed.
Mm-hmm. Dana, related to these post-discharge elements, quality parameters that you talked about, is that going to end up being a quality parameter to how efficacious the ACO is? Is that going to be one of the things they're going to look at, that how is the post-discharge planning, teaching, and monitoring, like of the patient I just said, is that going to be part of the quality factor that relates to the ACO either being penalized or being rewarded by doing a good job on that?
Yeah, so that's a great question, and I can answer for my own organization is to say, I don't think it will be a parameter on which there are additional quality payments. And the reason for that is the organization that prevents that readmission is already benefiting financially in the sharing of savings that occur by preventing that admission. So we've tried to structure the quality payments in a way that we're paying for things that otherwise aren't incented and that otherwise might become stinted on, and paying for patients' experiences of care. So we are in fact paying on a measure that has to do with patients' reports about how well that discharge instructions were explained to them in the hospital. It's a nationally administered and accepted measure, and it is part of the quality incentive dollars. But we all have to think carefully about where to add payments in the system to reward quality, and where the incentives of the global budget that allow for organizations that produce savings to share in those savings, which of those to have as the source of reward, I think is important. One other last point, which is that doesn't mean that the organizations don't need information to help them do those things. So we're providing all kinds of data and information to help be sure that those discharge elements are happening. That's different from whether we'll give additional money to make sure that they happen.
Okay, just checking. We have about 10 minutes for questions, and I'm sure there's a lot of people here that would love to throw some good questions at us. There's a gentleman right there.
Thank you very much, Doctor, for running a fascinating panel. Thinking as an economist, Professor Gruber has taken a look at the phrase accountable patients and has rightly said that an aspect of accountability is price signals, that this new paradigm somehow has to send price signals to patients who overconsume, perhaps. But as a good political observer, he's also pointed out that what sunk managed care were angry patients. So how are we going to square the need for ACOs to make patients accountable by sending pricing signals to them when they overconsume, with the fact that we're already walking a thin line in dealing with patient anger, whether it's produced by doctors or anybody else?
Dr. Gruber?
That's a great question, and I think the way that's going to happen is, I mean, I think we've already seen an answer to that, which is that insurers are going to move towards packages where patients are price sensitive because employers are going to demand it. I mean, if you look at small employers circa 5 years ago, maybe 10% of them had high deductible plans. Now it's about 80% of them offer high deductible plans. Why have we moved there? Because basically it's the only way small employers can make insurance affordable for themselves and their employees. So I think what's going to happen is employees are just going to face higher cost sharing. The hope would be that cost sharing isn't quite as blunt as higher deductibles, but some of the more kind of value-based insurance designs that Dana and Michael Chernow and others have worked on to try to really incentivize the right kind of behavior. But I think that, yeah, it's going to upset patients. Patients hate paying when they go to the doctor. But I think patients also, it really is in some sense, a lot of it can have to be driven by employers. And if employers say, look, this is the insurance package I can afford, I think patients will, I think employees will then live within those constraints.
Yes, sir.
Hi, yeah, my name is Stephen Pollack. In healthcare, I guess from my perspective, I always look at three key drivers, and I have a question related to this. One is we're not nearly as smart as we think we are. In a proverbial sense, we know a fraction of the clinical knowledge that's knowable. In fact, if you look at clinical guidelines out there, most clinical guidelines from cardiology to, in fact, cancer and the like are really value judgments, not based on good, hard data. And of course, that becomes much more complex with complex patients with comorbid conditions. The second piece of that is the problem is everybody's different. You know, we like to apply standardized protocols, standardized notions of processes, but the fact of the matter is everybody's different. If I treat everybody to a mean, my costs go up. In fact, I like to say means are meaningless in healthcare. The third piece, which has been addressed, which we're trying to do with ACOs, is this notion of aligning clinical and financial incentives, which I think is a really important notion, although how you do that is critical. But I do have one question, and particularly for Dr. Safran, which is we talk about aligning the incentives for the providers. To some extent, we talk about doing that for patients. But what about for payers? Patients flip plans too often. You know, we want to give everybody choice, but if everybody flips plans every 2 years, the reality is the payer has no incentive to focus on my medium to long-term care. It only has the incentive to focus on cost rather than effectiveness. How would you respond to that?
Yeah, so I actually believe that that payers have, at least in this market or markets like this, have enormous incentive to look after the long-term health outcomes for the patients and the near-term ones. Your point is exactly right. You know, patients can and do, either on their own or through their employer, change plans as often as every year. But the reality is that as a payer, you don't know which patients are going to do that, and you also don't know when they're going to circle back around to be your patient. So it is in every plan's interest, actually, to make sure that patients are getting the care that they need to avoid the adverse short-term and long-term consequences of failures in care.
So just as one statistics, Humana told me that 20% of their membership turns over a year. So the question is, do you tend to err on the side of cost cutting, or do you tend to err on the side of promoting the effectiveness? And it may be different for Blue Cross Blue Shield in Massachusetts, but in other parts of the country, it's clearly the former.
Well,
you know, I hate to sound like an economist, but you know,
that's okay. It's okay.
That is another reason why we want to put patient financial accountability front and center, because the patient does stay with the patient even as they switch plans. So it's a reason to put patient accountability as part of the solution, not just insurer accountability.
Dr. Ferris, any comment on those points?
No.
Okay. Next question. Yes, sir.
I'm a practicing internist still in the trenches, and I'll just give you a couple of perspectives I have on Dr. Safran's point that the patient's biggest problem is coordination of care. I would respectfully disagree. I think their biggest problem is access and costs of care, and the declining access to primary care physicians, primarily because reimbursements are too low. The ACO is basically a revised capitation model with a couple of extra bells and whistles called quality measures and so forth. The internal contradiction is the same as with the previous capitation model, namely that while physicians, particularly primary care physicians, are considered to be managers of care and responsible financially for the consequences of this supposed management that they provide, patients are allowed free access to roam as they will to get the care they think they want. They don't know how to measure outcomes, but they do know that hospitals with certain reputations and high costs are where they might want to get care if they have a high cost problem, such as cancer or heart surgery. They may not want to go to their local ACO community hospital, but want to go to the Brigham, where the primary care physician doesn't practice and has financial responsibility. That's the internal contradiction. I think Dr. Gruber addressed it, and I think Dr. Ferris addressed it, and I think until the financial responsibility is borne at least equally by the patient, then physicians are not going to be able to manage patients.
So I'd offer a couple of responses. You know, you make very important points, although I'd say the point about access is almost a contradictory one. On the one hand, worrying about access, on the other hand, pointing to the facts that patients, you know, are sort of roaming freely, and is that a problem? But in terms of primary care access, one of the things that we have seen from this model, both here locally but also a national effect, is a re-energizing of primary care as a field. For the first time in over a decade, we saw medical students choosing primary care and residents choosing to stay in primary care. That hasn't happened in a long time. Within the AQC model, I can tell you that because of the way the incentives are structured, every organization that has come into this, and it's now getting close to 3/4 of our network, has invested substantially in primary care, to the point where specialists are really concerned about what is their place in this new world. And so while I absolutely agree that we have had and continue at the moment to have concerns about access to primary care, a model like this is already showing the signs that it can do what we need, which is to right the pyramid so that primary care is really at the heart of healthcare, and you get to specialty care and subspecialty care really when that is absolutely critical and necessary, not because it's the expedient thing for primary care physician to do is to move you on, and something the patient's happy to have do because of the way financial incentives are set up. The other piece that I'll just add on your excellent point about patient choice is, you know, I think Dr. Gruber makes the right point that a combination of accountability in the plan, accountability in the provider world, and accountability of patients is how we're going to have to get there. And having patients have different cost sharing for receiving care in places that are the more expensive settings, but for which there is no evidence that the quality or outcomes are superior, is one very important way to start to address that. But the even more important way that I see happening already is every one of those patients would ideally like a physician whom they know and trust to tell them, where is the best place? Where would you send your mother or your daughter if they had this problem? And they will listen to those physicians if those physicians have an answer for them. And under a model like this, that's what the incentive is, for that physician actually to have an answer for them and to be able to help manage their care across a continuum.
Okay, we have just 5 more minutes, and I see 2 other people at the microphone. Yes, ma'am.
Good morning. Thanks for this great conference. My name is Kate Burke. I'm an emergency physician. I practice out in Milford, Mass. And I have a comment, and then I have a question for the panel. My comment is that we will only produce accountable patients for ACOs and for all of the ways that we take care of our patients if we communicate more clearly with our patients at that moment of time when a caregiver and a patient are departing one another, and we are giving them the information about our particular recommendations. As clinicians, we spend a lot of time on the front end, and in my opinion, the most important part of my encounter with a patient is what I am telling and explaining to them and their family. So we need to do exactly what Dr. Safran mentioned, which is to focus on those 4 dimensions of the transition of care. And I'm very interested to hear what has been successful, in particular, in the cognitive realm, in your experiments that you've been doing, in how you are educating patients better so that they can be a more accountable patient. Thank you.
Thank you very much. Last question.
So I'd actually like to take the definition of accountable in a slightly different direction, and this may be a question for Tim, but I'm not sure. It feels to me like one of the challenges beyond the financial accountability and cognitive understanding, et cetera, is how does our society view the role of the healthcare provider? And by way of example, many people in our country, I would speculate, would rather take atenolol and simvastatin than lose 15 pounds. It's just sort of viewed, I have this clinical problem, I go to Dr. Ferris, he gives me 2 prescriptions, and it takes care of the issue. That sort of healthcare as a transaction with the provider. To the other end of the spectrum is increase in risky sexual behavior because HIV is now viewed as a manageable chronic condition. The doctor can take care of it for me. So I'm just sort of curious, how do we also change the paradigm of the fact that the patient really does have a role beyond just a copay in being part of their healthcare?
Dr. Ferris, would you like to start that one?
Wow, that's a hard question.
Fortunately, you only have a couple of minutes,
Yeah,
so.
quick answer. I'm going to, maybe this isn't going to answer your question, Alex. I'm not sure I can answer your question because it gets at, to me, it gets at societal norms. And this is a healthcare conference. And societal norms are a bigger issue. But actually getting to those societal norms and into the patient-doctor relationship, here's what I view as I want these efforts to succeed. They're laying off teachers in my town, at my schools, just like they are in every other town in the United States, because we can't pay the obligations on the healthcare bill. So I got that. The engaged provider, you're looking at them. What I worry about in the set of incentives that are being placed on doctors is not the idea of placing incentives on doctors. I think that's essential. It's the speed and the details of which the incentives are ramped, are changed over time. And I guess it goes to something that Dr. Gruber said, which is, he said to succeed in this, the doctors are responsible for delivering less to the patients. I think that's a recipe for disaster. I think that will end this process and we'll go through another period. The recession, just like in the early 90s, the recession will produce a slowing of healthcare costs. This will all unravel and we'll be back at the table in 10 or 15 years trying to figure out the next iteration. There is a way to move forward here, and that is if we actually intend to bend the cost curve, and that is decrease the rate of rise, if we can fall into that narrow band, which is a compromise, because the politicians want less spend, not just decreasing the rate of rise, and I can assure you that Blue Cross wants less spend rather than decrease the rate of rise. But if we actually do come to a middle ground and just decrease the rate of increase and carefully monitor that and apportion the incentives appropriately, I think we can actually keep the doctors and the patients on board with the process, because we're not actually delivering less care. We're simply not delivering more and more and more care. That's going to be a tricky balance, but I think that's the
the road that's going to lead to success in this endeavor.
On that wonderful note, we're going to end our panel. Thank to all the panelists. And